Lise, I can see you're posting me in the chat, but I can't write anything in the chat at the moment.
Sorry, Ernst, Alice is just having a few technical problems. I think you can start, and I'm sure one of the other will pick up if she doesn't get it sorted by the end, if that's okay. Okay, that's good. So it's 10:15 now, so that's good anyway. Good. So again, a good morning or a good day or a good afternoon or even good night. There was someone from Canada who said it's 2 in the morning there and was asking for whether the lectures are being recorded and can be heard afterwards. So it's grim daytimes or night times for some of us. I would like to start now off with congenital malformations, and usually when we have the course in a physical form, this is actually 2 talks, 45 minutes each. So I tried to condense that into one 45 minutes talk, and by this it's clear that I cannot go into all the details here, but roughly give a brief overview on many of the topics. I do not have any conflicts of interests regarding this presentation, and what I will these are the aims. What I want to try to show you is the most important congenital malformations of the respiratory tract and also the clinical relevance. We'll talk a little bit about epidemiology, of course, anatomy, pathophysiology, and up to treatment and prognosis, but again, not in very much detail. I start off with airway malformations, and this is a table from the Pediatric Respiratory Medicine handbook. And as you can see here, the airway starts off with the nose or maybe the mouth. And this is the way I will work it through: nasopharyngeal airway, the larynx, and the trachea, and the bronchial tree. Obviously, not all of them will be covered in detail. If we start off with the nose, there is a number of congenital obstructive lesions of the nose. As you can see, I can divide those into cystic ones and solid ones. All of them are very rare. You will not be able to see many of those, even if you do, for instance, bronchoscopies for 20 or 30 years. I've only seen some of those, so very rare disorders here. Just to show you that there is a wide variety of possible pathologies. A much less rare, a much less rare problem, as you know, is choanal atresia or choanal stenosis. And the bony forms are much more common than the membranous ones. You see it's 9-to-1, and 2/3 of these children do have associated anomalies, for instance, the charge association. The symptoms or the signs are different depending on whether it's atresia or stenosis, or it's bilateral or unilateral. What is important here that you establish the diagnosis usually by flexible airway endoscopy and or CT scan. And there are different ways to treat these pathologies, which obviously I can't go into detail here. Just to show you an example, on the left-hand side, you see the normal choana, left and right-hand side of this baby. And on the right panel, you see the status post-surgery already. So this was complete atresia, not stenosis, but still after surgery, as when you compare it to the left side, you see that there's bilateral stenosis here still. This shows you a CT scan, and on the right panel, you see as compared to the normal situation on the left panel, you see a unilateral osteomembranous atresia. So it's the bones and also a membrane that close up here, what should be a lumen. If you go a little bit further down to from the nose or the nasopharynx to the oropharynx, there is the Pierre or the Robin sequence and many other pathologies as well. Just briefly, it's if you talk about Robin sequence, it's mandibular micrognathia, glossoptosis, and the resultant pharyngeal airway obstruction. The airway obstruction is of variable severity here, and also thus the treatment is variable. So in some cases, you don't have to do anything. In some cases, you have to do major surgery. The incidence is around 1 in 10,000. What is important is that more than 50% of these children do have associated anomalies, and more than 40 of associated anomalies have been described. Cleft palate is not always there, but very frequently associated with Robin sequence. This shows you the problem, also in a schematic drawing. It's the mandibular micrognathia, it's the glossoptosis, and the resultant pharyngeal airway obstruction. There are many more craniofacial anomalies which can compromise the upper airway. So dysmorphic syndromes such as Eber, Crouzon, and other syndromes are very well known. Altogether, it's at least 36 syndromes with craniofacial anomalies that are associated with one or more of also laryngotracheal malformations. So very often in these children, you do have to do bronchoscopy to sort out what's going on in the larynx or in the tracheobronchial tree. Stridor has been mentioned already by Fabio before, and it's a very, very important problem. It's often the most prominent symptom of upper airway obstruction. As you know, it's usually heard during inspiration, but also can be biphasic stridor during inspiration and expiration. And what it tells you is that there's substantial narrowing obstruction of the larynx and or the extrathoracic trachea if it's inspiratory stridor, meaning that more than 50% of obstruction is needed that the patient becomes symptomatic. I've seen children with much more than 50% of obstruction who did not show persistent stridor. Where does it come from? It's increased velocity and turbulence of the airflow, which leads to vibration of structures like the epiglotic folds or the vocal cords. And there has been a term coined by Bob Wood, one of the pioneers of flexible bronchoscopy in children, which is stridor is visible. What does it mean? It means that if you do flexible bronchoscopy in a child and the child has stridor during the investigation, then you have to find the pathology because you will see what's going wrong unless you're not experienced. Stridor is visible. It is important, and Fabio has pointed it out, that children with persistent stridor, the examination has to be during spontaneous breathing, because if there's no spontaneous breathing, you may miss the pathologies. And the most common congenital laryngeal anomaly is Laryngomalacia, and it's also the most common cause of persistent stridor in infancy, and Fabio has already told you a little about that. It's a specific disease state, but the pathogenesis is ill-defined. There are different forms, as I'll show you in a minute. There's still some discussion whether it's anatomical abnormality in some of the forms or delayed development in neuromuscular control. And also, as been pointed out by Fabio, again, it's worsened by the application of lidocaine. At least 1 or 2 studies are clearly showing that, but there's a little bit of controversy about that. I mentioned types of Laryngomalacia, and there are many classifications actually around. This is the one that is very common from Loring Hollinger from the US, and you see there are 5 types. I don't go into all the details here, just showing you this classification, and there are many others. And this is a more recent one from a group from the Netherlands, only distinguishing 3 types. As I told you, many classifications, not so important, in my opinion, which classification you use. You should be able to describe clearly what is going on. For instance, in the middle picture here, you see the typical floppy epiglottis. On the right-hand side, the posterior displacement of the epiglottis. On the left side, you see this inward collapse of the arytenoid cartilages. And there may be combinations of various types. Also short epiglotic folds, which is one of the types of the Hollinger classification, is not so rarely associated with other types. So Laryngomalacia, as you know, the onset of stridor is usually within the first days or weeks of life. Again, I don't go into all the details here. The diagnosis is usually its history, physical examination, and as already Fabio pointed out, it's very often to be confirmed by flexible airway endoscopy because you may have additional problems here. In a case with a very mild stridor with no additional symptoms, you probably do not need flexible airway endoscopy in all those cases. Laryngeal web, the next pathology, can come in very different forms. Most of them are glottic webs, but supraglottic or subglottic webs have also been described. They may be complete, which is it's bad news obviously for the child, or incomplete. More often they're incomplete, and they may be very thick or just very thin webs, membranous forms. And depending on the form, it's varying degrees of respiratory distress. Example given biphasic stridor, hoarseness, aphonia. Again, diagnosis is done by airway endoscopy. Treatment, again, differing because of the different forms. A few examples here On the left-hand side, you see a very thick, so there is no membrane. It was really like 5 millimeters in height, glottic and even subglottic web. There was only a very tiny hole to the posterior aspect here. This is a glottic web again, but incomplete and membranous. And this is a subglottic web with a hole here of about 2 to 3 millimeters in diameter. So many different forms. So symptoms and signs and symptoms vary here. Subglottic stenosis. If you talk about subglottic web, obviously this is also already one form of subglottic stenosis. And what we are talking here about is congenital subglottic stenosis. So we are not talking about the acquired forms. If you have acquired subglottic stenosis, by the way, it's mostly iatrogenic, so it's due to intubation or tracheostomy, etc. When it comes to congenital subglottic stenosis, we're differentiating between two forms, which is the membranous. This is the more common form, characterized by symmetrical thickening of the soft tissues in the subglottic area, and the rarer form, the cartilaginous form, with variable appearance. Symptoms, again, are different because of the different forms and the different severities, and the treatment is, whenever possible, a conservative approach with surgery only reserved for the very severe or the more severe forms. This is showing you just one example, which is a combination actually of two types of subglottic stenosis. What you can see here is this symmetrical narrowing in the subglottic area. So this is a membranous congenital subglottic stenosis, and this child had already had to undergo surgery, so had to be intubated. And what you see here is this subglottic cyst. So this is an acquired subglottic cyst, so acquired subglottic stenosis on the basis of a membranous congenital subglottic stenosis. What's very useful here in terms of grading the severity is using this classification system by Meyer and Cotton, already put forward many years ago. You can see here grade 1 from no obstruction to 50% of obstruction. So 50% obviously means not in diameter or radius, but in cross-sectional area. And I mentioned stridor before, and stridor only develops up from here. So you need to have at least a grade 2 stenosis or airway obstruction in the larynx and or trachea so that stridor develops. These children here are usually completely asymptomatic. Subglottic haemangioma was already mentioned by Fabio as well. It's not a congenital lesion, but it's an important differential diagnosis here. I mentioned it here, it's most common tumor in infancy. And what is very different here, endoscopically, this is important, it's an asymmetric mass usually. So the congenital subglottic stenosis of the membranous form is a symmetric problem. This is asymmetric problem. But endoscopic recognition may be difficult because the surface or the mucosa may look completely normal, and it may be hard to recognize sometimes. I don't go into all the details here in terms of treatment, etc. Just showing again an example. This is a unilateral subglottic stenosis here. You can see it on the right side, and the corresponding MRI, which we did because the child had also cutaneous hemangiomas on the neck and also in the face. So we wanted to see how deep this actually goes, and you can see here it's only an airway hemangioma. Laryngeal cysts again can come in different forms. They're usually supraglottic. Again, if it's a subglottic cyst, it's usually an acquired subglottic stenosis due to trauma. Anterior and lateral cysts have been described. And again, depending on the location and depending on the size, obviously, there is maybe stridor, there's maybe respiratory distress, sometimes hoarseness or a weak cry or even aphonia. Again, the diagnosis is done by endoscopy, and there's clearly one treatment, which is resection of the cyst. Laryngeal cleft, one of the rarer congenital anomalies, but probably not as rare as people think, because many of them are not detected, especially when it comes to type 1 laryngeal clefts. They may extend inferiorly very deep, even into the trachea, and they may be, and very often they are, associated with other anomalies of the larynx, the trachea, and or the esophagus. Again, stridor. Why stridor? Because the larynx is not stable in the supraglottic area, and this leads to collapse, and this causes the stridor. But obviously also, if it's more than a type 1 cleft, and even sometimes with type 1 clefts, you will have you will see aspiration in these children. And even with ongoing aspiration, even damage to the lungs. I mentioned the types already, and this is again one of the most common classifications, distinguishing 4 types. Type 1 is a supraglottic cleft only, no further down than the vocal cord level. Cleft 2, if it goes beyond the vocal cord level, but the cricoid cartilage is only partially involved. And this is, I'm going back to this slide. This is a type 2 cleft here, because you can see the inferior margin of the cricoid cartilage here. So it's not completely split cricoid cartilage. So it's type 2 cleft. This is a probe in the esophagus here, and this is the trachea further down. And it can go even further down into the thoracic trachea as far as the carina, and this would be a type 4 cleft, obviously very bad news for the babies. Tracheo-oesophageal fistula, with or without esophageal atresia, again, a more common malformation with an incidence about of 1 in 3 to 4,000 babies. About a third of them are born prematurely, about every 5th of them has a low birth weight, and more than half of them do have associated anomalies. You know all about the FATR or the fractal association. What is very important here, even after the problem is fixed by surgery, that the vast majority of these children do show structural anomalies of the tracheal wall, and this is tracheomalacia. Survival rate obviously depends on the form and the associated anomalies, etc., but usually is good. You know all these different forms. There are different actually classifications. This is the most common here, with the upper blind pouch of the esophagus and the distal fistula from the lower trachea to the lower esophagus. And this is the so-called H-type fistula here, where we do not have esophageal atresia, but just the fistula. And this fistula usually is not here, as it is depicted here, but usually if you have an H-type fistula, this one is located in the extrathoracic trachea, so very far up usually. It can be very difficult and tricky to establish the correct diagnosis, usually by endoscopy, flexible and or rigid or contrast injection. But many cases have been described with lots of difficulties, because these fistulae can be very tiny and can be very easily overlooked. Much rarer than with esophageal atresia. You see only 1 in roughly 100,000 kids. So this for Austria, this means this is only 1 child in Austria per year. I mentioned trachea, and this is an old paper, but a very good paper. They looked at 40 tracheas from children with tracheoesophageal fistula, and they found that only 6 of those were entirely normal. 30 had deficiency of cartilage, and in only 9 patients, the abnormalities were restricted to the site of the fistula. So very often you do have more airway problems than just the fistula. And what is seen here in the majority of patients, that it's a reduced circumference of the tracheal cartilage. So it's not like what you usually have 4 to 5 to 1 the membranous portion, but a widened membranous portion here, which makes the trachea unstable. There's a lot of, as you know, a lot of problems even after surgical correction of the problem, in terms of both the airway or the respiratory tract and also the gastrointestinal tract, with all the morbidities involved. Again, I cannot go into all the details here. Survival clearly depends on birth weight. I mentioned many of the children have a low birth weight, many of them are premature, and of course also on the associated abnormalities and pulmonary complications in case they develop. Tracheomalacia is kind of a common congenital malformation. The incidence is estimated to be around 1 in 2,000 children, and it's different forms, but all of them have in common that it's weakness of the airway wall, and this may be due to reduction and or atrophy of longitudinal elastic fibers, or, and this is sometimes also in combination, impaired cartilage integrity, so-called immaturity also of the cartilages. All that causes the airway to be more susceptible to collapse, and this leads to retention of secretions from the lower airways, and this again results in bronchopulmonary infections. When it comes to severity, there is no universally accepted classification of severity, and sometimes it's also very difficult to judge during endoscopy or other investigations. I mentioned that already before. You see, this would be the normal trachea here with 4 to 5 to 1 when you compare cartilage to membranous portion, and this is this widened membranous portion here, as you very often see in children with tracheo-oesophageal fistula, and this clearly makes the trachea unstable. What you can see here is this is the cartilage. That cartilage may be disrupted here, so there's no cartilage integrity, and again the airway wall will be unstable with that. This shows you an endoscopic pictures, or two rather, during inspiration and expiration of intrathoracic tracheomalacia. So during inspiration, the intrathoracic tracheomalacia is more or less normal, because during inspiration, because this part of the trachea is widened during inspiration, during expiration, you see the collapse here, and this may be even total collapse, so that the anterior and the posterior walls are getting in touch. A typical lung function picture here would be if you do a maximal flow volume curve in such a child in this intrathoracic tracheomalacia, you would see the plateau here during the expiratory limb of the maximal flow volume curve, corresponding to the partial collapse of the trachea. There are many classifications around. You can clearly define or differentiate between congenital and acquired lesions. In children, for instance, with bronchopulmonary dysplasia, long-term ventilation, you may have acquired airway malacia. You can differentiate between localized and generalized forms, and between primary forms and secondary forms due to compression of the airway. And you see some of the examples here, and I'll show you a few more. This was a boy with persistent wheezing, so the diagnosis that was, or the wrong diagnosis that was established was asthma, and that what the child actually had was primary tracheomalacia. And this is showing a still picture again of the trachea here, and you see this collapse as before of the intrathoracic trachea during expiration. The child had already had, before it was referred to us, this CT scan with a 3D processing, and you see the trachea looks completely normal here, and also the three-dimensional reconstruction obviously must be normal then. And I show you this picture because I want to emphasize that virtual bronchoscopy or tracheobronchoscopy cannot replace a flexible bronchoscopy, so true bronchoscopy, which is still the gold standard if it comes to airway malacia, be it tracheo or broncho or tracheobronchomalacia, and there's a recent reference to that. First question. An 8-year-old girl presents with recurrent episodes of dyspnea, wheezing, and cough in the course of viral infection. In addition, she lags behind in school sports. A physician suspected bronchial asthma, but anti-asthma medication did not improve the situation. The physical examination is unremarkable. Lung function testing demonstrates a plateau in the expiratory limb of the flow volume curve, and flexible airway endoscopy shows narrowing of the trachea, as you can see here in the picture on the right side, and also the posterior aspect, as you can see here. Which is the most likely diagnosis here? Is it abnormal innominate artery, abnormal right carotid artery, abnormal right subclavian artery, double aortic arch, or pulmonary vascular sling? Please vote. Is nobody voting? Okay. So half of those who voted opted for pulmonary vascular sling, and this is the correct answer. Okay. I have to close this. Okay. Sorry. This slide shows you in a schematic drawing the very typical endoscopic views you may encounter if it comes to vascular anomalies and the airways. And some of them I will show you, some of those typical pictures. These were the options you also had in the questions. So it's mainly double aortic arch or a right aortic arch with the left patent ductus or ligamentum arteriosum, the so-called pulmonary artery sling, which actually is an aberrant left pulmonary artery, and the anomalous innominate or left carotid artery. And I'll show you a few examples here briefly. This is not one patient, but these two pictures are from one patient. This is the endoscopic view, and this is a CT angio. This is a conventional angio, so a historic picture if you would like. And this is another option to diagnose this double aortic arch, because if you do a barium swallow, this is the AP view and this is the lateral view, you will see the indentation because also the esophagus, not only the trachea, is in the midst of this arch. This is the typical endoscopic view you can see here. You see this on the left-hand side, it looks more or less normal. And there is this major compression here from the anterior and from the right. Again, this boy, 7.8 years of age, already persistent wheezing, misdiagnosed as asthma. The corresponding CT angio shows you very clearly here the trachea and one of the arches and part of the other arch. So double aortic arch, a very important differential here. And this picture you already saw before, and this is the corresponding MRI angio. And what's the problem here is that the left, this is the view from behind, the left pulmonary artery originates from the right pulmonary artery and then crosses behind the trachea and in front of the esophagus to the left-hand side. This was only diagnosed in this girl at 15 years of age. The girl had recurrent wheezing, so there was not persistent wheezing, but whenever she had a viral respiratory tract infection with additional swelling of the mucosa, she developed this wheezing episodes. This is a very common problem actually, and very often it is not a real problem because growth of the child and aging helps. If it's a problem, it's always in infants and maybe toddlers. This is the compression of the trachea by the innominate artery. So when the innominate artery originates from the aortic arch a little bit to the left and the posterior, it has to cross to the right-hand side in front of the trachea and may compress the trachea. This is very often not a problem you have to tackle in terms of surgery as you have for other vascular malformations. Airway-malacia symptoms, as you can see here, a long list of symptoms. We mentioned stridor, I mentioned wheeze, obviously depending on the severity, respiratory distress, even cyanosis, blue or dying spells, etc., etc. So many symptoms you may see in these children. And so there's also a long list of differential diagnoses, obviously, here. How can you treat that? Again, only briefly. Most patients can be managed conservatively. So if that's possible, you should go for it. If you have to do surgery, and this is taken from the recent ERS statement on tracheobronchomalacia published last year, aortopaxy or posterior tracheopaxy in localized forms can help to solve the problem. Sorry, there is, okay, it's quiet again. So long-term application of CPAP or PEEP may help in generalized forms, and only in highly selected patients you should think of a stent here. This is just showing you that with positive airway pressure, you can treat some of these children with generalized forms. You see here a PEEP 2, 4, 6, and 8, and you see in this flow, in this tidal flow volume loop, the compression here and the gradual normalization if you increase PEEP. Congenital tracheal stenosis, again, can come in very different forms. There's a short segment stenosis or long segment forms. Again, these malformations are frequently associated with other anomalies like pulmonary artery sling. So there's a strong association between the so-called red tail trachea and pulmonary artery sling, but also with other malformations as abnormal bronchial arborization. This is from a publication from the Great Ormond Street Hospital group showing you what they encountered in a given period of time in terms of their kind of classification. You see this is for congenital tracheal stenosis and congenital tracheobronchial stenosis in association with, for instance, a tracheal bronchus here and other malformations. Trifurcation means that you have here the left main stem, the right main stem bronchus, and kind of a tracheal bronchus that went down here to the bifurcation, which is then made a trifurcation. Only a few examples, or only one example here, the endoscopic view of a very severe but very short tracheal stenosis just above the carina. There's an additional pulmonary or parenchymal malformation here as well in this child. How to treat? Again, finding a tracheal stenosis. Sometimes you find a tracheal stenosis as an incidental finding is not an indication for surgery. So if the child is asymptomatic or only mildly symptomatic, you should go for a conservative approach at least first. And then there are different options as well. What it needs, if you need more complicated surgical procedures like slide tracheoplasty, you really need to look for an experienced center, because only those will do any good for the child in such a case. Tracheal bronchus I already mentioned before. What is it? It's an ectopic or even a supernumerary lobar or a segmental or subsegmental right upper lobe bronchus that arises from the lateral wall of the trachea, and it's always the right lateral wall. You can see that in 1 to 2% of bronchoscopies, and very often you also find structural abnormalities. So it's not only a right upper lobe, an apparent right upper lobe bronchus, but usually you'll find malacia or stenosis or other abnormalities in such a case. Also, stenosis of the distal trachea is in many cases associated with these problems. And other malformations, depending on the series you look at, in 60 to 100% of the cases. So very often more than just a tracheal bronchus. This is such an example. This shows you the trachea here. You see already tracheal narrowing here before the tracheal bronchus arises from the right side wall. And then it goes a little bit further down here, and you see the right and the left main stem bronchus here. So this is tracheal bronchus in combination with tracheal stenosis, which is depicted here with complete cartilage rings. And this is the orifice of the tracheal bronchus here. Tracheobronchomegaly, just briefly, is a very rare anomaly. It's as the name says, it's dilatation of the trachea and the main stem bronchi with tracheal outpouchings. And this, in terms of pathophysiology, this is very much similar to tracheobronchomalacia because it's unstable walls. And finally, with all the respiratory tract infections that will develop in very often develops to bronchiectasis. Showing you one example, we see this very wide trachea here and also the very wide right and main stem bronchus. You see outpouchings already here on the CT scan and even more clearly in this endoscopic view of the trachea. Very rare lesion. Willis-Campbell syndrome, also very rare. It's just a form, if you want to put it like that, of generalized bronchomalacia, because there's deficiency of the cartilage in the tracheobronchial tree. So you will have a generalized bronchomalacia. This is one of siblings I looked after, and you see this is at around 9 or 10 years of age. You see this massive hyperinflation because of the generalized bronchomalacia in this child, and this is lung function here. The child developed bronchiectasis, and this was biopsy to establish the diagnosis, and there was just no cartilage in the subsegmental bronchi. Second question, which of the following statements regarding congenital diaphragmatic hernia is correct? 5 years post-surgery, forced vital capacity is likely to be within normal limits for age. 40% of affected infants have an associated cardiac, renal, or chromosomal anomaly. It is more common on the right side than on the left. Persistent pulmonary hypertension is a rare complication in the neonatal period, and tracheo-oesophageal fistula is a commonly associated malformation. Please vote.
Don't worry, Ernst, there's a lot of people voting.
Okay. I enjoyed the break. Okay, so 57, so 3 out of 5 are saying that 40% of affected infants have an associated cardiac, renal, or chromosomal anomaly, and this is correct. This is the correct answer, and I will cover the false answers during my short presentation now on congenital diaphragmatic hernia. So we kind of finished this short run through airway malformations, and I'm continuing now with congenital diaphragmatic hernia, only a few words. What's the problem here? The septum transversum is developed incompletely. Again, this is not so rare a lesion, with around 1 in 2,500 or around 4 in 10,000 live-born infants. The majority of these problems are on the left side, so up to 90%. And again, of those, the majority in the posterior aspects of the diaphragm, the so-called Bochterleck hernia. About a quarter of these hernias are in the anterior aspects. This is the Morgagni hernia, and only a minority in the central parts of the diaphragm. 40% of these children, this was the correct answer before, do have associated anomalies. And this can be everything like cardiac anomalies and or other ones. What's the problem here for the lung? Obviously, this will lead to lung hypoplasia on both sides. It's more on the ipsilateral, obviously, than on the contralateral side, but also on the contralateral side, usually there's lung hypoplasia to a certain degree. And what is this lung hypoplasia characterized by? It's reduced size bronchi with less branching. It's also decreased alveolar surface. It's a reduced number of pulmonary arterial tree divisions, like for the bronchi, and it's increased thickness of the arterial walls, which leads to the complication of pulmonary hypertension very often. And what's remarkable here is that not much different to like 10 years ago or 20 years ago or so, survival still remains at about 60 to 70%. Even with all the sophisticated treatment modalities, if you take all the congenital diaphragmatic hernias together, not only of those who were born because pregnancy was not interrupted, it's only up to 60–70% survival. The most critical factor for prognosis here is the degree of lung hypoplasia. Only a few examples. This is obviously on the left-hand side. So this is a typical Bochterleck hernia and the posterolateral aspect here. Here it's mainly liver, again, the left-hand side. This is the right-hand side, and this is an anterior hernia. This is a so-called Morgagni hernia here. And this is again on the right-hand side. This is liver up in the right hemithorax. A picture from an ERS statement. From an ERS task force, and you can see here in this autopsy specimen the right lung, which is hypoplastic, but even more so obviously it's the left lung. So this is this ipsilateral and the contralateral lung, and obviously the child could not survive due to this massive diaphragmatic hernia. There have been actually many papers and also updates, and this is again the ERS task force paper with very clear recommendations both for the antenatal and also for the postnatal management of infants with CDH. And obviously, for the sake of time, I cannot go into details here. I just wanted to show you that there are recommendations, if you're not aware of them anyway, also for the postnatal treatment in terms of indications for ECMO, what about the timing of the surgical repair, etc. And this is updated recently, and this is published in Neonatology is in 2016, I think, because I can't see it here on my screen, is the most recent update I know of. What are the causes of mortality and the causes of mainly respiratory morbidity here? It's one, the lung and the vascular developmental abnormalities, but also the postnatal management can cause complication, including hyperoxic, high pressure mechanical ventilation, prematurity, which is very often in association with the hernia, and obviously all the associated anomalies in up to 40%. There's a high incidence of morbidities in the respiratory tract, nutritional, musculoskeletal, neurology, and also the gastrointestinal tract. So these children, as many others as well, have to be followed up by a multidisciplinary team to do the best for these children. Another question to kind of keep you awake. You're requested to assess an asymptomatic term newborn infant with a prenatal diagnosis of a congenital thoracic mass that on prenatal ultrasonography at week 26 looked like a type 1 congenital cystic adenomatoid malformation, so with large cysts affecting the left upper lobe. However, chest X-ray obtained the first day showed no evidence at all of such a thoracic mass, and after a very careful review, the chest X-ray was considered normal. The most appropriate next step in the evaluation of this infant is order a CT scan to detect or rule out the thoracic mass, order sonography to definitely rule out the thoracic mass, perform infant lung function testing to assess the functional impact of the regressed mass, reassure the parents that the thoracic mass is completely regressed, no further testing is needed, repeat chest X-ray at 6 months of age to assure complete regression of the mass. Please vote. Very good. I must say that you could argue about some of the answers because you might do one, not only one, but two out of what is suggested here. But the majority of you, 53%, would what I would say is the right answer, order a CT scan to detect, rule out the thoracic mass. I will come back to that during the next few slides. We will now talk about the third and last part, which is on cystic malformations. And first of all, I have to tell you that there is a real problem with nomenclature here. If we look back a little bit, like say, a little bit like 20 years, everybody was talking about cystic malformations. And this was talking about lung cysts, you see an example here, then cystic adenomatoid malformation, you see an example here, pulmonary sequestration, you see it here, very tiny in the cardiac shadow, congenital lobar emphysema here, the left upper lobe, or a bronchogenic cyst, you see it here in the typical location, one of the typical locations in the right paratracheal region. So all of those were called cystic malformations. Problem here, obviously, is that some of these so-called cystic malformations do not even contain cysts, like it can be the case in pulmonary sequestration or in a type 3 CAM. And this is the type 1, type 2, type 3 CAMs, as was put forward by Stocker many years ago. You know that this is the macrocystic form, this is the microcystic form, and this is the so-called solid form. Still, it's called a cystic lesion. And this led people to think about nomenclature very much. There's a paper from Andy Bush already now 19 years back, new kind of a plea here really for a clear nomenclature. And what he suggested, I'll come back to that later, is this term, congenital thoracic malformation, so CTM. So putting all that together, the CAMs, the CCAMs, the CPAMs, the sequestration, etc. What could be the sense in doing so? So why you should lump all those entities? I'll come back to that. Another classification came up again by Stocker, who had put up the type 1 to type 3 before, and now added the type 0 and the type 4. It's not called CAM anymore, or CCAM, but CPAM, congenital pulmonary airway malformation, and this was the current classification at that time. What's very important here is that it was thought that this one, the type 1, which with the large cysts, is one of the common malformations here, as common as the type 2. This is actually not the case. As you can see.
Excuse me, it's Alice. You've got only a few minutes left if we want to have some time for the questions.
No, yeah, but I will leave time. I will leave 10 minutes for the questions. I'll be fine. Yeah.
Okay. Because
okay. Thank you.
Okay.
This is from a recent paper from the States looking at close to 200 consecutive cystic malformations, and what they found that when it comes to mucinous cells, they only found that in type 1 lesions, so in no of the other lesions, not type 2, not bronchial atresia, not bronchopulmonary intralobar or extralobar sequestration. And this is very important because these are the cells that are progenitors maybe of carcinomas, So clearly type 1 is a risk factor for malignancy, for development of malignancy. But what they found here is that type 1 is not as common as it was thought. Going back to this slide, so this is rather a rare lesion actually. So it's not common. And this is the first paper clearly showing that this is a rather rare lesion. So the risk of malignancy is only here. This is not one of the common forms. There's another risk for malignancy, which is pleuropulmonary blastoma, which comes along with this type here. This is type 4, again with large cysts. This is clearly related to regressed pleuropulmonary blastoma. Okay, another classification, no details here, congenital lung malformation put forward by Pierre Langston's group, another trial of putting that in some order. And I'm coming now back to what I like very much, because it's very different to say beforehand, before you have histology, to clearly say what it is. So I prefer the term congenital thoracic malformation. Why? Because there's a common embryological origin with significant overlap between all these malformations. And very often you will find hybrid lesions. Hybrid lesion is if you have an anatomical extralobal sequestration, for instance, but the histology is like a CCAM or CPAM, ELS and CCAM in the same patient, and it looks like a CCAM, but you do have an accessory systemic blood supply, as it was considered to be typical for sequestrations. So many of the lesions I see in my practice are actually hybrid lesions. This is just one example. You saw that before. It looks like a CCAM with large cysts. This is the chest X-ray, this is the corresponding CT scan. You see here the solid and the cystic portions. But this child had a huge vessel originating from the abdominal aorta feeding this malformation. So clearly a hybrid lesion here. The antenatal natural history is completely unpredictable. So the growth pattern is unpredictable. If there is a large lesion, which is usually diagnosed if you do prenatal sonography around week 20, this does not necessarily correlate with a poor prognosis. If there is high drops, the prognosis is clearly poor, but many lesions decrease in size over time. And this is referring to the question, some lesions completely disappear on ultrasound scans, and even on postnatal ultrasound for chest radiograph, they're very often undetectable. Most of them, however, can be detected by CT or MRI scanning. This shows you one of two papers, which shows that this is individual measurements here. This is the cam volume ratio. So you see the individual measurements, and you see here the mean cam volume ratio and also the quadratic regression. And you see that the biggest size for the whole group, but you see this wide variety here is around 26, 27, 28 weeks of gestation. And then there is a tendency for the lesions to get less big. This is from the French group showing pretty much the same. Christophe Delacour from Paris showing that this is again a large series of malformations, and again showing the cam volume ratio for the whole group and for the hyperechoic group and the mixed group here. And there is a tendency from the peak here around 25 weeks to lesions that are getting smaller and smaller. So very rarely it is the case that you have to do something in fetal life, and even less than 20% of these children will have respiratory distress with the first months of life. So the vast majority of these lesions, like around 80 to even more than 80%, are completely asymptomatic, but they are prone to develop complications like infection, pneumonia, abscess, and pyema. Only rarely cyst rupture, which may lead to pneumothorax, and again, rarely malignant transformation. I've already talked about that. In terms of investigations, you have several modalities here. I already pointed that out. What is very important in my point of view is to avoid specific prenatal diagnosis and prognosis, because you usually cannot tell the parents what will be going on. What's very important, I mentioned that already, that all patients with antenatally detected congenital thoracic malformations do require postnatal evaluation. In utero, you will not have to treat many of these children. This is only a slide for orientation, different options here. And this is a group of highly selected fetuses where you should do that if the anomaly is really life-threatening. And obviously, you do need a highly skilled multidisciplinary team to do that. The symptomatic patient, this is quite easy. because surgery is the accepted standard of care for symptomatic lesions. It's also indicated when a postnatal complication arises or if antenatal treatment has already been performed. So then it's quite easy to find the proper way. It's then different types of surgeries that can be performed. It's formal thoracotomy or mini thoracotomy or VATS, embolization, I put in brackets here. It's much more complicated for the asymptomatic patient. Many children with antenatally detected congenital thoracic malformations will be asymptomatic at birth and the neonatal period, as I pointed out. And many authors put forward different strategies, even for different lesions, talking about compensatory lung growth and also about the risk of surgery that has to be balanced with the need for repeated CT scans and also the potential loss to follow-up. Just a word for Elise, we started at a quarter past, so I will end up at a quarter past and I'm at the very end. So there's really a debate, ongoing debate in the literature, what shall you do with the asymptomatic children? Asymptomatic lung malformations, is it the right way to do not surgery, but to just wait? What will happen to these children? We do not have really good information on that. This was a group of 39 children that were followed non-operatively, and a third of them had eventually to undergo resection. These were the older children, and these were the children with larger lesions. So obviously, the longer you follow up these children and the larger lesions you are, the greater is the risk that you have to do the resection. And this has also been shown by this Australian group. If you look at the large, medium, and small-sized lesions here, that it's 2/3 here of the large lesions that become symptomatic, and also these children obviously then have to undergo surgery. What about the literature? There is not too many. This is a systematic review, not too much information on that. It's only 350 children that made it to the systematic review, and 2/3 of them received elective surgery, 1/3 was managed conservatively, and of this 1/3, again, a quarter developed symptoms, so that about a quarter of the whole group remained asymptomatic after this observation period. As you can see here, that is not very long in my eyes. So that at present, most of the authors do recommend operation, surgical treatment in children with bronchogenic cysts, in all aerated sequestrations, and in all lesions with visible cysts on CT scan. Observation in congenital lobar emphysema if they're asymptomatic or only mildly symptomatic, and unclear for other lesions like this segmental hyperlucency. The timing of surgery is important as well. It's the second last slide. As complications develop very often in the first 2 years of life, people try to postpone surgery beyond the first 3 or 6 months of life because of the risk of anesthesia and surgery, and to be just ahead of complications. But the key recommendation of timing of surgery cannot be given yet. And if you look at that, published recently, this is from the American Pediatric Surgical Association. They asked the right questions and looked for the evidence for that. So what is the long-term risk if observation? What should you do? When should you do what? They found that only level 4 and 5 evidence here, so case series, expert opinions. So the grades of recommendation also are only D. So there's a lot of uncertainty here, and we'll await properly performed prospective trials to find the answer for many of these questions. So thank you for your attention. I know this was a rush through. I had to do it in 45 instead of 90 minutes, so please bear with me because of that. Thank you.
Thank you, Ernst, for your talk. Now I will ask you the question that were asked by the participants.
Okay.
So first one is about the upper airway malformations. What are the criteria to do flexible bronchoscopy in a few months old child with Stridor?
That is, I mentioned that already. If the child is a few months old, and already, and it depends on when the stridor did develop. So, and also if it's persistent stridor or not persistent stridor. So it's difficult to answer this question. What I wanted to say before is that if it's persistent stridor in a child and it's only mild, and history and physical examination very much point to the most common form, which is Laryngomalacia, and there is no additional pathology and the child is growing well, there's no cyanosis, no nothing, then you not necessarily have to do endoscopy. But very often parents of such children are very anxious, and sometimes this also can be a good indication to do a bronchoscopy, because you don't need to do a bronchoscopy really here. It's sometimes only laryngoscopy, and in a few seconds, without a lot of sedation, you do have an answer. So I would recommend to do bronchoscopy whenever there is any uncertainty, actually.
Okay, thank you. Second question, how to decide if laryngeal lesion is a cyst or haemangioma only on a visual examination by endoscopy? What are typical appearance?
So the differentiation between haemangioma and cyst, I understood?
Yeah.
I mean, I mean, usually it's not so difficult to differentiate a cyst from a hemangioma, because cysts usually look like cysts, so they have this more bulgy and more like a ball-like look. But if you really cannot differentiate and you want to find out if it's hemangioma or not, you could go for an MRI scan, because hemangioma really can be nicely depicted in MRI scan. I find it more difficult sometimes to differentiate between, if it's only a small hemangioma, between hemangioma and a membranous subglottic stenosis, not so much with a cyst.
Okay, a question about tracheomalacia. What do you think about the method to diagnose and describe tracheomalacia in patients with a history of esophagus atresia, described by Choi and Jennings? It's a dynamic three-phase bronchoscopy to describe abnormalities during swallow breathing, Valsalva procedure or cough, and during distension of the trachea using expiratory pressure using PEP. Is this extra information worth the extra time needed for a tracheobronchoscopy? Sorry, it's a long question.
Yeah, sorry, it's such a long question that I really didn't get the question. I mean,
I think the participant read about three-phase bronchoscopy technique to describe tracheomalacia in three different settings. One is during breathing, spontaneous breathing. The other one is during a cough or a Valsalva procedure. Yeah. And the last one is during you will distend artificially the trachea using positive and expiratory pressure during the bronchoscopy. And so she is wondering if this is really an indication to evaluate your tracheomalacia. I don't think so, but you will answer.
Okay. I agree with you. I think you would need such a procedure only in very exceptional cases, because usually history, the physical examination, and just the bronchoscopy you do during spontaneous breathing tells you the picture and leads your way for treatment.
Okay. Does tracheal bronchus also predispose to recurrent infections?
Yes, very often it does, because very often the tracheal bronchus itself does show stenosis or malacia. So due to the associated anomalies, it very often does. If it's a tracheal bronchus and it's a normal bronchus, it should not predispose to infections, but it could be a problem in a child that has to be intubated because the tubus, the ETT may bypass the origin of the tracheal bronchus, so may block it. So atelectasis or pneumonia will maybe develop in such a child on long-term ventilation.
Okay, let's go to vascular malformation. If you have a prenatal diagnosis of double aortic arch or right aortic arch without any symptoms after birth, are you just observe and wait, or are you exploring and treating?
So there's a prenatally established diagnosis already, and the child is asymptomatic at birth.
Yeah.
Yeah. I mean, obviously, I would follow this baby very closely, but obviously also I wouldn't go for surgery within the first days, weeks, or let's say 3 months of life if the baby is asymptomatic. It will not stay asymptomatic after at least a couple of months or so have passed by, I'm sure.
I agree, but are you performing right after birth a chest CT scan to confirm?
No, if we can avoid it, we also try to postpone chest CT scans until the child is at least 3 months of age.
And will you associate the chest CT scan with a bronchoscopy to have the complementary exploration of the anomaly? Because it's what we do in.
So you say
we perform both the chest CT scan and the bronchoscopy.
Yes, we do.
Okay.
Yeah.
Again, a question about tracheomalacia and laryngomalacia. Is there an indication for salbutamol in children with such anomalies, or will it worsen the symptoms because of the muscular relaxation?
Yeah. Actually, you can do a lot of discussion about that, and theory is not always like practice here, because in theory, a bronchodilator should further should increase the instability of the airway wall. It should not do any good. So you can even put it the other way around. You might even, but you obviously won't do that, by doing methacholine or histamine inhalation, you may even stabilize the airway. Obviously, you don't do that. But in practice, if you have got a child with, say, both tracheomalacia or bronchomalacia and asthma is a clear indication for bronchodilators, usually these children still benefit from a bronchodilator. But you have to clearly, closely look at the child and to look at the effects of such a treatment.
Okay, some questions about congenital diaphragmatic hernia. Someone was asking about the management of diaphragmatic eventration in infants.
Eventration.
Yeah.
Yeah. Again, very much depending on the symptoms and the problems of the child. Mm-hmm. I mean, clearly, if the child is well, you would watch and wait, as with all these informations, I think, or almost all of them.
Okay, how long a child with a post-op congenital diaphragmatic hernia should be followed for any respiratory symptoms?
Again, if there's a lot of respiratory mobility, you would probably even, I would follow this child as long as it is in the pediatric age range, and if there's ongoing problems, which very often are the case, I would hand over to an adult pulmonologist then.
Okay, I agree. And a few questions about CCAM. What is the preferable surgery for congenital cystic adenomyotrophine malformation, I guess, or cystic malformation?
Sorry, what type
is the preferable surgery? I think it's about thoracoscopy or
this again depends on the size of the lesion, and this again and also on the local experience. So if there is no experience with thoracoscopy, then obviously you would go for mini thoracotomy or thoracotomy. And sometimes if you start off, our pediatric surgeons in Graz are very experienced. But they sometimes start off with VATS, and then they have to resort to formal thoracotomy. So again, very much depending on the individual case.
Okay, and two last questions.
I was just going to say, Alice, actually, we've run out of time for now. So brilliant interaction, lots of questions, but we're going to have to prepare the next speakers now.
Okay, I will send the questions to Ernst in the chat box. Okay, thank you.
Thank you.